Welcome to another episode of the NEI podcast. I'm Dr. Sabrina Siegel with the Neuroscience Education Institute. In today's episode, we are coming to you from the 2023 NEI Synapse in Nashville, Tennessee. Today, we sit down with one of our incredible speakers in this special extended Q&A episode to give you a chance to get your unanswered questions addressed from selected presentations. In this episode of the NEI podcast, we are talking with Dr. Roger McIntyre, who just finished his presentation called The Mania Event, Distinguishing Between Treating Bipolar 1 and Bipolar 2 Disorder. We are coming to you from Nashville, Tennessee, from the 2023 NEI Synapse. And this is so exciting because this is one of our exclusive extended Q&A episodes where you get a chance to have some of your unanswered questions addressed from today's presentation. So welcome, Dr. McIntyre.
Sabrina, great to be with you.
My first question for you is, how common is a significantly elated mood without excess energy? Does elation cause an increase in energy?
You know, it's such a great question, and it has both a conceptual element to it, but also a clinically meaningful and relevant part to it. Let's just start with the concept. Elated mood speaks to mood, and an increase in energy often speaks to what we call motivational or approach. And typically what happens in bipolar disorder, when someone is experiencing a hypomanic or manic episode, they have an increase in mood and they have an increase in their reward anticipation, which is driving some of that excess energy. So the short answer to the question, Sabrina, is that the great majority of people have both. Said differently, and answering the question directly, only about 20% of the time, maybe 25% of the time, does a person have elated mood without excess energy. They tend to march in the same direction. But what we can see is people who have excess energy and rather than elated mood, more irritable moods. So excess energy and change in mood tend to go together. It's not that they cause each other. They tend to march in the same direction. The usual metaphor I put forward for this is that we know that diabetes and hypercholesterolemia both march in the same direction. They highly correlate, but they're both very different. So that's a similar metaphor to what's going on here.
Right. And this was it was such an incredible presentation, so much information.
Oh, thank you.
So we do have quite a few more questions than we typically pull for this episode, but they just kept flooding in. So we're going to try to get through as many as we can today. So my next question for you is, what is a way to assess for rapid cycling? Is it as simple as just asking, have you had 4 or more manic, hypomanic, or depressive episodes that have taken place within a 12-month period?
You know, it's such a great question. I think it is important to distinguish rapid cycling because it is a very unstable form of bipolar disorder. And the question provides the definition, 4 or more episodes in a 12-month period. But how do we ask about it? Certainly, if memories are perfect, then I think just simply asking the patient, during the past 12 months, have you ever had a 2-week more period of depression? And similarly prefacing, in the last year, have you had a period of mania or hypomania? Now, some people, not many, some are especially skilled at being able to recall this information, recall it reliably. Some are very detailed and they know even the days of the month that it happened and so on. But most times that's not what we have. What we have is a lot of I don't knows and memories are not perfect. So the best way, frankly, Sabrina, to assess for this is a couple of things. If the patient has a mood diary tracking their symptoms, I find that very, very helpful. If they don't have a mood diary, is there a third party, a loved one, a friend, a partner, whatever the case may be? Can that help in providing additional information? And then thirdly, it's more difficult to remember what your mood was like a year ago or 8 months ago. It's easier to remember what you were behaving like. In other words, 8 months ago, you don't typically forget if you were off work for a couple of weeks. You may forget what your mood was like, but you don't forget that. Or you don't forget a period of time where you broke up with a relationship because you were being inappropriate, you were overly active, or, things like that.
Mm-hmm.
So I tried to anchor it to some behavioral manifestation
Right.
if I don't have a mood diary or third-party input.
That's excellent. Okay, this next question I think is great. It says, please speak to the effect of trauma on people with bipolar disorder.
It's such an important question because trauma is a very common event, not just in adulthood, but in the childhood history of an adult living with bipolar disorder.
Mm-hmm.
In short, it's a very, I think, well-characterized story now that it exerts problems on every level. First of all, trauma is associated with an earlier age at onset of bipolar disorder.
Mm-hmm.
Interestingly enough, bipolar disorder in persons reporting trauma is also more likely to be severe, rapid cycling, mixed, associated with comorbidity like drugs and alcohol, as well as suicidality and additional comorbidities like personality disorders. Mm-hmm. So taken together, when someone says, I have a history of trauma recently or in my childhood, what you can be almost assured is that this is going to be a more complicated illness. Now, it's also interesting that there's literature now showing that the underlying neurobiology may be affected by trauma in their past. And that's something we're looking at academically. But I think that in short, we're looking at a more complex, more severe, difficult to treat illness. And then secondly, I think one needs to be prepared for a much more integrated approach. In my clinical experience, 25 years and counting and doing this, you always have to address some aspects of the trauma, whether it be in psychotherapy, whether it be in some type of supportive arrangement, etc. So I think it does speak to the need for integrating psychosocial treatments with medication.
Right. Okay, the next question I have here says, when you have a patient who is type 1 diabetic and treatment of bipolar depression exacerbates the diabetes symptoms, what do you use to move them to remission?
Well, first of all, type 1 and type 2 diabetes are not uncommon in people who have bipolar disorder. And I think for me, when we talk about someone who has bipolar disorder and diabetes, we're going to prioritize treatments that don't cause glucose dysregulation, treatments that don't directly cause impaired insulin signaling, and treatments that don't cause significant weight gain. And in keeping with that, the treatments for bipolar depression that come to mind for me would be cariprazine, lumateperone, and lurasidone. They have to be prioritized in any patient with bipolar depression, but especially in the adult living with bipolar depression who also has a concurrent diabetes disorder.
Right. Okay, the next question is, are cognitive challenges influenced by medication management choices?
They sure are, Sabrina. What we do know is that, first of all, 2 out of 3 people who live with bipolar disorder exhibit cognitive difficulties. We also, these cognitive difficulties are very persistent, can be very problematic in day-to-day life, personal life, work life, family life, social life. And we do know that in some cases, the cognitive difficulties are a consequence of the medication. For example, benzodiazepines can interfere with cognitive functions. In some cases, sedating antipsychotics can contribute. Other patients will exhibit reduced cognitive functions as a consequence of anticonvulsant treatment administration. So I think, like most considerations in psychiatry, what we're doing is we're looking at what is the benefit risk analysis. I do think that all clinicians should probe patients, query them about the possibility that their cognitive difficulties are a consequence of the medication. And if so, what's the benefit and what can be done about it? But it's a very significant contributor to cognitive impairment.
Right. Okay, next question. How do you navigate treating pregnant women with bipolar 1 versus bipolar 2?
Yeah, this is such a great question. I agree, Sabrina. This is such an important question. And the other part I would say to this question is that I think that this determination about bipolar disorder in pregnancy is a different conversation in the first trimester when compared to the second and third. As everybody knows, the first trimester is the time where we see rapid organ develop and so on in the fetus. It's a time of higher vulnerability relative to the second and third trimester.
Right.
The second point is that when I had trained as a clinician, when I was a medical student, I remember, Sabrina, being told that pregnancy is a time of protection against bipolar return of episodes. That's not true. It's actually a time of risk.
Right.
And so we can't just have people not treated. So I think we need to go into this with the consideration. Of course, these are shared decisions. Obviously, this is the woman's decision, but we need to provide accurate information. And the accurate information is that bipolar needs to be treated in pregnancy, needs to be treated in postpartum. I think the considerations around postpartum, specifically breastfeeding, that clearly depends on the medication, and they should discuss that with their care provider. With respect to treatment in pregnancy, many medications we do consider in pregnancy. Lithium, lamotrigine, second generation antipsychotics, FDA approved for bipolar, we would definitely consider. And these are really selected on a case by case basis. So in short, I would just say guiding principles are, I would be considering treating. The considerations are different in the first versus the second and third trimester. And I think taken together, one should consult a registry. There's a wonderful antipsychotic registry, Sabrina, at the Massachusetts General Hospital in Boston. It's a national antipsychotic registry that people can just call up and ask questions about the safety of antipsychotics, which are commonly prescribed in bipolar during pregnancy.
Wow, that's excellent. Okay. Is there any research supporting a history of significant childhood trauma as a commonality among individuals with bipolar 2?
It is a really important question to suss out which subtype of bipolar disorder is most associated with childhood trauma. If we look at the literature today, where we land is that both bipolar 1 and bipolar 2 have, unfortunately, relatively high levels of trauma. We cannot say that one particularly has a higher risk than the other. What we can say is that for both bipolar 1 and bipolar 2, the hazards of trauma are huge with respect to affecting age at onset, illness presentation, suicidality response to treatment, and comorbidity course and outcome. So it is really a very, very poor prognosticator when someone has trauma. But for now, we're not in a position to assert that bipolar 2 or bipolar 1 is more susceptible or more likely to report trauma than the other.
Okay. This person asks, is borderline personality disorder absolutely a part of bipolar 2 phenomenology?
What I would say is that bipolar 2 disorder and borderline personality disorder are very different mental disorders. They're very different in how they're defined. They're different how they're operationalized, their presentation, their course, their outcome, their family history. It's all very different. So I don't think that borderline personality disorder is simply part of bipolar 2. I think they're apples and oranges. But just like apples and oranges share in common that they're both fruit, borderline personality disorder is characterized by mood instability, cognitive instability, impulsive behaviors, changes in sleep, many aspects that overlap with the phenomenology of bipolar 2. And I can say for years and years doing this has been a very difficult diagnostic differentiation. Right. I really go back to a guiding principle for me. For me, the core disturbance in borderline personality disorder is a disturbance in forming secure attachments.
Right.
In bipolar disorder, the core disturbance is a dysrhythmia. Something's wrong with the rhythm of mood, cognition, circadian rhythms, and behavior. That's not to say they can't have an attachment disorder, but that's not the primary problem.
Right.
And when you take a careful history, listening very carefully what your patient is saying to you, I find that most times this just, frankly, suss itself out on its own. But they're not the same. They are different organisms, just like an apple and an orange are different. They just share a lot in common in the sense that they have common phenomenology.
Interesting. That was a great answer, by the way.
Thank you.
The next question is, what is the incidence of a first hypomanic or manic episode above age 40, especially in women?
Such an important question clinically, diagnostically, therapeutically, and conceptually. The short answer is 10%. That's the answer to the question. So what that we conclude is that, close to 90% of people with bipolar have declared the illness before the age of 40. The remainder, 10%, is after the age of 40. And we call this later age onset. There's this other phrase, Sabrina, called old age bipolar. If you have it after 50, I cringe. I don't think 50 is that old, but anyhow, old age bipolar is after 50. But the short answer is 10%. And what's interesting, Sabrina, just to add a little bit of color to this, is that people who have an age at onset of bipolar after 40 or 50, they are less likely to have a family history of bipolar disorder and more likely to have a personal history of cerebral vascular disease. So that alone gets you thinking, this doesn't seem like exactly the same organism as bipolar disorder that's earlier in life. And it's true. So that's a very interesting set of observations, but 10% approximately is the answer.
So interesting. Wow. The next question is, which treatments have the best data in rapid cycling?
With respect to treating rapid cycling bipolar disorder, the best evidence would support the second generation antipsychotic agents. Okay. In other words, there's a variety of these agents. Most of these patients are suffering from depression. And when you look at the FDA approved treatments for bipolar depression, many of them have also looked at, either through their original trials or through post-marketing or through academic studies, patients who have rapid cycling. I might also add to that list, if I could, lamotrigine is another agent that we not infrequently consider in rapid cycling alone sometimes, but more typically in combination with the second generation antipsychotic.
Wow. Thank you for that. The next question that we have is, could you comment on high dose range of lamotrigine for bipolar depression and the reason for this?
The dose range for lamotrigine in bipolar depression is not entirely agreed on, in the sense that there have been varying doses used in clinical trials. Moreover, it's also been studied in combination with other drugs like lithium. So then it begs the question, is the dose the same in combination versus on its own? Those just comments aside for a moment, what I could say is that my experience would overlap with the trials that were done with lamotrigine, where most of my patients require at least 100 to 150, and the great majority 200 to 400 milligrams a day. So my short answer would be prepare for 200 to 400 milligrams per day. Some may ask, well, what about the risk of rash? Well, the risk of rash is a real risk, but that risk is mitigated if you start low, go slow, titrate slowly. And if you go according to that guiding principle for lamotrigine, rash has not been a serious issue in most patients.
Okay. The next question, this person says patients really don't want to take lithium.
Yes.
How do you talk to them about it?
Well, I agree with the comment. It's clear that patients don't like to take lithium. And when you go on to do a search on Google, for example, you put in lithium, I've done this many times, you're not getting a story that would make anyone develop an appetite for lithium. Never mind someone who's being recommended to take it for many months and years. In other words, there's just a lot of information that's out there. Now, I think we're going to start off by saying there's a lot of misinformation out there, which is true. But there's also information that's out there that needs to be contextualized. In other words, we've all seen side effect lists associated with medication. Well, if most of us looked at the side effect of aspirin or Tylenol, we would never take those pills. So one needs to actually work with patients. And my experience has been is that, yes, you want to serve as an advocate, provide accurate education and information, but it begins with trust. No one's going to learn and really be convinced of anything if you don't trust who your educator is. So you got to develop a working alliance. The working alliance is working together, shared decisions, and I think a heavy dose of psychoeducation. And psychoeducation, like just like going to school in university or high school. To get the course right, you have to sometimes have multiple lessons. Mm-hmm. And I think we need to revisit this issue. I've had patients who said, nope, I'm not taking it, not taking that stuff. That stuff is dangerous, this kind of thing. And I respect someone's decision-making and autonomy. And if I might revisit that and we'll have a candid conversation. I explore what some of their concerns are. Often the concerns are entirely valid. Sometimes the concerns are really misinformation and things like that. But it begins with candor. It begins with having that working alliance. But I think it's a very, very heavy dose of psychoeducation.
Mm-hmm. Mm-hmm. Is there a link between the research on the SLC6A4 gene and reactivity in the ventral striatal region?
Such a great question. I would just say it's a work in progress. This is a very interesting question because we typically think about a genetic and a phenotype. Do they have bipolar? Do they have depression or mania? But there's what's called intermediate phenotypes. And so when you look at not so much what's on the surface, that is the mania, depression, or mixed, but instead you're looking at a brain region, in this case, the ventral striatum, the reward region. That's an intermediate phenotype. And just the sort of the guiding principle with this, Sabrina, is the closer you bring the phenotype to the genetic, the better you get an association. So there's a lot of interest in looking at the link between genetics and some type of marker, like a brain reactivity. And this is work in progress. But we can't say for sure yet that ventral striatal reactivity is entirely the consequence of any single gene, but it is an area of very, very active research.
Mm-hmm. Mm-hmm. Fascinating. The next question I have is, this person says, is it just that the studies haven't been done, or is there a reason that second generation antipsychotics will work in bipolar 1, but not in bipolar 2?
Great question. The answer is that most of these drugs have just not been studied. The only FDA approved agents for bipolar 2 disorder depression are quetiapine and lumateperone Caplyta. Mm-hmm. And the other drugs, there's many now that have been looked at, like cariprazine or Tuda, that also have bipolar 1 depression indications. They have not been studied in bipolar 2 disorder. So the short answer is just not been studied. We need more work in the area, without doubt.
All right. Well, we can look forward to that, right?
Yeah, absolutely. 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 And just to put maybe a little fine point on something here, Sabrina, is that some might say, well, hang on. Well, why not? Why aren't they being studied? Mm-hmm. And, I would say that there's always a longer story. So I'll give the short story. The short story is that because the diagnostic agreement on what bipolar disorder actually is not as high as the agreement that exists for bipolar 1. Frankly, there's less than optimal confidence in doing studies in bipolar 2. Now, clearly, we can diagnose bipolar 2 with this great studies. We got data for quetiapine, we got data for lumateperone. But to be perfectly frank, that warrants or that invites the need to have very skilled diagnosticians, good checks and balances in place for quality assurance. And that's what the studies for lumateperone, Caplyta, and also quetiapine had that allowed them to confidently say, we have data. So I think it's part of this lack of certainty that's made it less attractive to some to study. But now we're learning so much more about bipolar 2 depression, how severe, how hazardous it is. I think you're going to be seeing more studies in this space.
Excellent. Excellent. Can you touch on the use of brexpiprazole in bipolar disorder?
Really interesting question. And, I have, since I first became familiar with brexpiprazole many, many years ago, had a view strongly that this is a medication that should be studied in bipolar depression and bipolar depression with mixed features. Mm-hmm. It is approved in major depressive disorder, and its pharmacodynamics and its profile of efficacy in depression, that is that it helps anxiety, it helps anhedonia, helps disengagement type symptoms, lassitude, fatigue. This would be ideal for the bipolar population. Mm-hmm. For reasons that are less related to the science and more related to decisions that are made about medications and how they're developed by companies. The company made a decision more strategically for them that wasn't scientific necessarily, that they weren't going to study this drug in bipolar depression. Instead, they have been studying it in agitation and Alzheimer's disease,
right.
and also in PTSD. So we'll look forward to seeing those data sets when they're made all available to the public.
Mm-hmm. Mm-hmm. The next question is, when do you consider offering electroconvulsive therapy or ECT to your patients?
Yeah, great question. Two parts to that question as I see it, Sabrina. The first part is, when does it first cross my mind? And then secondly is, when do I start having that conversation with the patient?
Right.
I think that ECT, generally speaking, crosses my mind when someone's had 2 good trials of FDA-approved treatments for bipolar depression and the patient's still not well. So I think that sort of third option, I'm starting to think now in my mind ECT. I might even have that conversation at that point. But my experience has been is that 9 out of 10, 99 out of 100 patients do not want ECT at that point, and they want to consider alternatives. So it crosses my mind after 2 failures, but I don't typically, in fact, put that front and center as the only way to go next. In most patients, we consider other options. Now, ECT, I think, should be considered first line in some situations. I've had some women who are pregnant, who have a depressive episode, and we then find out that they got bipolar disorder right in pregnancy. This was when they're first diagnosed, and the depression is so severe, so impairing that it's compromising their health and also the pregnancy. That is a medical emergency, and ECT would be the treatment of choice. It would be a first-line treatment. Of course, that's a very severe medical emergent situation. Outside of that, I would say consider it after 2 failures, but I think most patients would say, thanks for letting me know. Let's put that in the parking lot for now. I want to try 2 or 3 other treatments first, and then let's revisit that. And of course, that's perfectly fine. But I just think people should be made aware of options.
Yeah, absolutely. Okay, well, this takes us to our last question, which is a bit longer. But this person says, how often do you see premenstrual dysphoric disorder, or PMDD, misdiagnosed as bipolar 2? Many female patients I encountered seemed to actually have severe PMDD rather than rapid cycling bipolar, but appeared so due to the cyclic nature of PMDD. What are your thoughts on this?
Oh, wow. Such a wonderful question. I think this happens more commonly than we even know. I think that there are many examples where women who have premenstrual dysphoric disorder are misdiagnosed as having either cyclothymic disorder or bipolar 2 disorder. Just a reminder that cyclothymic disorder, the person doesn't have hypomanic episodes, manic episodes, or depressive episodes, but they have hypomanic and depressive symptoms that are unending for a couple of years in duration. And it gets worse for some women premenstrually. But what I would say is that for me, what we're looking at is a not infrequent situation where PMDD is misdiagnosed. Hard to know for sure how common it is, but here's what I say to everybody. And that is that in any woman who is presenting with PMDD, query about bipolar disorder, and anyone who has bipolar disorder, who's reproductive age, ask them about PMDD. It's a standard question, a routine question for every patient I've seen in my career.
Excellent. Excellent advice. Well, thank you so much, Dr. McIntyre, for such an incredible presentation and for taking all of this time to answer some of these great questions. Thank you all for joining us here at the 2023 NEI Synapse.
Thank you.
Thank you so much for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today.